has decided upon for these therapies. When looking at the history of some of these treatments, it dates pretty far back, about 30, 40 years at this point, where chloroquine at least was used and studied in vitro for its potential of antiviral activity. And then through the years, it's been studied in a variety of other viruses and diseases such as SARS coronavirus, influenza, dengue. They tried again in a different type of influenza, Ebola, Zika, and now they are looking at treatment in potential COVID-19. And based on this one article that highlighted kind of the history of this, it also mentioned that if in fact this is proven as a treatment, this would be the first success that they have seen over this history. When considering any new article that comes out, we have been able to review hopefully some of the more important ones in this presentation, but definitely looking at this short little history of just the year 2020, weekly publications have been sort of skyrocketing and kind of have stopped at this point. I don't want to say stopped, but they definitely continue to keep publishing. I think what we do have is we have a lot of literature, but we have very scarce evidence at this point for these therapies. This is a graph that came out of an article in The Lancet, and it does a pretty good job showing you different symptoms as well as disease progression for inpatients when comparing survivors and non-survivors. So as you can see, fever and cough is essentially the presenting symptoms that these patients presented with and eventually progressed to either an ICU admission and or potentially ARDS requiring intubation, sedation, potentially proning, and whatnot. So at this point, these patients present fairly similarly, and about day 10 is where day 10 to maybe 12 is about where we start to see the patients either crash or sort of start to make a recovery on their own. This is a graph showing more of a pharmacokinetic standpoint. These were patients that were not treated. These patients received nasal swabs and they used a PCR CT value. And what this essentially is showing is that a lower CT value correlated with a higher viral load. And over time, these patients, again, did not receive treatment, but by about day maybe 10 to 12, they did start to see viral clearance, again, without treatment. Just keep that in mind, as a lot of these studies try to look at viral clearance and they use these CT values as their reference point. There are many treatments that are being considered and or studied, so I'm not going to go through all of these, but these are some that have had at least some literature that's been published trying to either support or refute their use, mainly antivirals, hydroxychloroquine are anti-malarial, potentially azithromycin and whatnot. This is, again, just showing us how these patients may be progressed from stage 1, 2, to 3 if we were to divide them into 3 categories. The symptoms these patients present with are relatively not super specific, and these patients are then considered for hydroxychloroquine based on some of the literature right now. They may progress to eventually the stage 2 or pulmonary phase where they develop shortness of breath, hypoxia, and then they eventually progress to this hyperinflammatory state where we start to consider ARDS. Maybe they're entering a cytokine release sort of storm or syndrome, as you will, where we would maybe consider corticosteroids or even IL-6 inhibitors. Rush a couple weeks ago between the ID attendings and ID pharmacists worked on some approval guidelines and where they would consider the use of certain agents. So starting with hydroxychloroquine, this medication is used based on the theory of its mechanism of action, interfering with entry into cells of this virus by potentially increasing endosomal pH, which is required for this viral and cell fusion. The doses that they were initially using and still are considering are listed there on the slide. again, monitoring parameters for hydroxychloroquine. Some of the big ones are this QTc prolongation, as well as hemolysis that we should be sort of concerned for these patients where the benefit may not always outweigh the risk. And then azithromycin has also been studied. This may have antiviral activity, and it also may inhibit the production of other anti-inflammatory responses. Lopinavir, ritonavir, probably more commonly referred to as Kaletra, the brand name. The lopinavir component blocks the main protease of this SARS-CoV-1, which can help inhibit replication. And then the ritonavir is again just used in combination as a booster. This agent, I would have liked to just cross off on this slide, but because we did initially use it in-house, I wanted to include it, but I'll explain a little later why we no longer are pursuing Kaletra as a therapy. And then we also have tocilizumab, where may be referred to as simply Toci. This is a therapy that has existed for the cytokine release syndrome due to its mechanism of action of being an IL-6 receptor antagonist, more commonly used and understood in the HEMONC world, where these patients are potentially getting CAR T therapies. Remdesivir is probably the newest, maybe going to have one of the stronger studies that we will be able to briefly mention later. Remdesivir inhibits the RNA synthesis, and right now it is the only intracellular antiviral that we have for this disease state. Why do we use hydroxychloroquine, even though a lot of these old in vitro studies use chloroquine? Long story short is hydroxychloroquine is an analog of chloroquine. It has better safety as well as fewer drug-drug interactions. And from more of a, I guess, pharmacokinetic standpoint, it has a lower EC50, which is the value that requires at least 50% to have its inhibitory effect. So the first study that kind of brought hydroxychloroquine into, I guess, our realm of therapies most recently was this open label non-randomized study. They looked at nasal PCRs, positive COVID patients who were hospitalized on general medicine floors. They essentially broke it up into 3 groups, classifying patients as asymptomatic upper or lower respiratory tract infections. Overall, very low numbers in this study. The control group consisted of 16 patients not receiving therapy, and then 20 patients received hydroxychloroquine, and 6 of those 20 received azithromycin in addition. And they were looking at viral clearance by about day 6. So when looking at their primary outcome, here we have what they're considering a 70% viral clearance as of day 6 in this study with hydroxychloroquine plus or minus azithro, whereas the control only had 12.5%. And then they further break it down, where here in the green you can see hydroxychloroquine in addition to azithromycin, whereas the blue 57.1% was
Anthony, I think we lost your volume.
until maybe this doesn't happen again. But looking at this study, they broke down the data for the primary outcome of looking at viral clearance. They had 2 groups for now. They had the hydroxychloroquine plus or minus the azithromycin, and they saw 70% viral clearance, whereas the control group, again with no treatment, only saw 12.5% clearance. Then they further broke down the data to stratify it based on hydroxychloroquine plus azithromycin in the green, which achieved 100% viral clearance by day 6. They also looked at just the hydroxychloroquine group alone, which had a clearance of 57.1, and again, the control at 12.5. Based on this data, they made conclusions that hydroxychloroquine in combination with azithromycin suggests a synergistic effect of combination, as well as needing further studies to confirm this finding. So about a week or two later, they same authors published another article looking at a very similarly designed trial, single-arm, open-label, non-randomized. They did nasal PCRs as well to find the COVID-positive patients. Again, general medicine patients. These patients were followed for about 6 to 14 days. They used hydroxychloroquine, and they gave everybody azithromycin in this study at the same dosings from previously, as well as considered ceftriaxone plus or minus if the patient was to be considered for potentially a bacterial pneumonia. Looking at the clinical outcomes, they were referring to patients as requiring oxygen therapy and or admission to an ICU. Only 15% of these 80 patients in this study required oxygen therapy. Only 3 of them required transfer to ICU. And kind of looking at some of the way they published their baseline characteristics, these patients had relatively low news scores, which is what they use to determine the severity. So these were not super severe patients that were presenting in this study. They also used PCR CT scores with a cutoff of 34 to determine what they were trying to classify as contagiousness. Other studies don't really necessarily use the word contagiousness, but again, they were claiming patients, about 83% were negative by at least day 7. They also looked at clearance in cultures, as well as duration spent on an ID unit, like their infectious disease floors, which was about 4 days. Overall, looking at least these 2 studies, which may be 2 of the best that we have published so far, providing some sort of guidance, they are small samples. They don't have true comparators. The second study technically had no control. They're based on virologic clearance, not necessarily symptoms, which, as we know, may be pretty severe for these patients. The enrollment into these studies varied. The first study, these patients were enrolled when they started on treatment, but not necessarily the day after they presented or started having symptoms. So in the first study, these patients were about 4 days into their course. In the second study, they were about 5 days into their course. And neither study really provides any information for these critically ill patients. There were some dropouts in the first study. And again, people were excluded from the second study if they weren't alive or 6 days after their enrollment. So we weren't following these patients for super long-term sort of outcomes at this point. Kaletra, this was one of the other medications that was actually started to be used, and they created order sets here at Rush and was being implemented up in the ICUs. This most recent article came out for it was looking at hospitalized patients with confirmed COVID. They were trying to find some of the severe patients with oxygen saturations less than 94 and PaO2s and FiO2s less than 300. It is one of the larger studies that we currently have published for therapies in COVID. Standard of care patients included 100, as well as the patients that did go on to receive Kaletra was about 99 patients. And they were looking at clinical improvement. They determined this to be an improvement of 2 points on a 7-category ordinal scale, or just consideration for discharge from the hospital. And what they had found is that over time, Kaletra had really no benefit over their control with a hazard ratio of 1.24 with the confidence interval crossing or confidence interval between 0.9 and 1.72. So here, this study, based on their primary outcome, really proved that there was no benefit in adding Kaletra to these patients. And then looking at some of their secondary outcomes, such as mortality, median time to clinical improvement, and adverse effects, there really was no true difference here for these patients, as well as looking at their viral load clearance. And then one other thing that I want to add here about Kaletra, because we won't really mention it moving forward, is that not only did this study prove there really was no additional benefit, but clinically speaking, a lot of the ICU pharmacists have been noticing drug interactions with midazolam that is being used up in the ICUs. these midazolam drips, but these patients are remaining sedated much longer than they had expect. And part of that is being attributed to the potential 3A4 drug-drug interaction with Kaleidra. Now we're going to discuss some investigational therapies that are being studied. When we are talking about tocilizumab, we have to talk about the cytokine release syndrome. And what is cytokine release? Essentially, we have these T cells in our bodies that help in an immune response. They release cytokines that further stimulate macrophages, dendrites, endothelial cells to then go on and create more IL-6, which then further causes a positive feedback loop to help upregulate T cells to fight any sort of response. And correlating with this, these patients tend to move through 4 different grades, basically less severe to more severe. So grade 1 being fever. Grade 2, these patients start to experience hypotension. And then grade 3 and 4 are more severe, where these patients are experiencing shock, hypoxia. These are the patients where we start to consider potential intubation. Here's another graphic looking at some different biomarkers from that Lancet study that looked at survivors versus non-survivors. So the non-survivors are in red and your survivors are in blue. And why we talk about this right here is that they did try to use some of these biomarkers and looked at levels in the study for tocilizumab. One thing I wanted to point out after a conversation with our ID pharmacists here is that are looking at ferritin as well as some of our troponins and CRPs for these patients, as they're more reliable markers. And I wish I can put that in air quotes, but those are what they're considering to be more reliable for the progression of this disease in regards to potentially using tocilizumab treatment versus some other places. And this study also mentioned LDH, but they're not finding too much with LDH here. So tocilizumab, they looked at in a retrospective single-arm observation study. Again, these were hospitalized confirmed cases. They divided patients into either severe or critical. Critical essentially requiring intubation, mechanical ventilation. And what they did at the beginning of this study is they checked IL-6 levels, which we do not do in-house. This would be a send-out, I think, if at all. But these patients were presenting with very high levels of about 132, whereas a normal level in this study they were using as a cutoff of less than 7. And these patients were receiving what I would say standard of, care at this moment in time when they were adding on toci. So these patients were already receiving lopinavir, methylpred, and oxygen. They also were allowing up to 2 doses in this study based on if patients still continue to have fever within 12 hours. Majority of these patients only received 1 dose. Again, it was a very small study. I think only a total of 21 patients here. And they were really only looking at clearance of these biomarkers or decrease in these biomarkers. So CRP and temperature were some of the main findings here, where they returned to essentially normal after 5 days. Remdesivir, this is a hot topic right now. They're considering this to be an antiviral that inhibits RNA-dependent RNA polymerase, again, only intracellularly. This is available through an expanded access program right now. There are 2 clinical trials that are occurring. We are actually a site for those 2. We have one for moderate patients and one for severe patients. I won't go into inclusion and exclusion criteria for each of those. And the biggest thing here is that the ID physician needs to try to enroll these patients into the study. So this is not something we're just ordering and starting on these patients. This requires a much more approval process and enrollment process. But again, it is being looked at in adults and pediatrics. And then I just wanted to touch upon some additional treatment considerations that we've probably been hearing about and talking about both down in the EDs and as well as up in the ICUs. So this was a pathway that was created to help determine if your patient should be receiving an albuterol MDI versus a nebulizer or nebulization. This came from a critical shortage of MDIs where we were running into concerns in the beginning of this disease progression, wondering if we should in fact be still using MDIs, both from a shortage standpoint, but also from an exposure risk to healthcare providers. So I won't really go through this. We may have either seen this or you'll see it when you do try to order your inhaler. But in the top left, if it's on the way on your screen, top left photo is that Aerogen Ultra Set that was, I know, discussed a little bit at the end of Dr. Patwari's discussion, but it is essentially a closed sort of system that is allowing nebulized treatment. Another concern is anticoagulation. In these COVID patients, there's risks of DIC as well as VTE. And then I included on the right a graph, again, from those non-survivors versus survivors looking at their D-dimer levels as it progresses throughout the disease state. Some pharmacologic approaches have been mentioned and or briefly started to be mentioned in some of the literature. There was a study that looked at prophylaxis dosing using heparin or low molecular weight heparin, such as enoxaparin. And they were looking at 28-day mortality. Overall, there was no difference in mortality, but when they broke it down based on some of their more higher risk patients, such as a 6 score above 4 or a D-dimer above 3, that is where they saw some more benefit in this therapy. In regards to treatment for if we were to have confirmed PEs, there was this pharmacokinetic study that looked at some of the D-dimer levels in these patients who were testing positive on CTPA for acute PEs, and they were finding that these patients that in fact did have COVID and have PEs had D-dimers up about 11, and those that were negative were closer to 2.4. The one thing that I want to include here is sort of a little joke, but also not a joke, because this actually happened last week where we had a COVID rule-out patient who presented with a D-dimer of about 27, and the concern here was, do we not start heparin in this patient, even if we weren't able to visualize any sort of PE or VTE. Corticosteroids has also been a discussion. The rationale here is that it is an anti-inflammatory, anti-fibrotic, and it can potentially prevent this extended cytokine release. The World Health Organization, as well as CDC, makes some recommendations to not use in patients with COVID-19 for treatment of their viral pneumonia or ARDS, unless patients have asthma and COPD exacerbations or are progressing to septic shock. The sweet spot really here, we're not really sure when we should be starting or using these agents, but again, at least avoiding them in our general medicine population or non-severe rule-outs. Antibiotics, I think, is a big concern down in the emergency department where these patients present, and we don't want to miss any diagnosis. So we start to consider these patients as having community-acquired pneumonia. So we start to think of our standard ceftriaxone, azithromycin. More recently, there has been concern for potentially running out of azithromycin or going on critical shortage. As of right now, there really is no mention or no true confirmation that we are running low on an oral supply of azithromycin. But there's also potentially using doxycycline. It is mentioned in the CAP guidelines. Azithro is probably still a better option, but I did notice one day Vanessa at least started using doxycycline and ceftriaxone when we were really not sure if we were going to hit a shortage or not. So that's what prompted that conversation on the right side of the screen. But I will say up in the ICUs that these patients, once confirmed any sort of viral pneumonia or COVID positive, they are stopping these treatments pretty much immediately. When it comes to rapid sequence intubation, which will probably be happening down in the emergency department, and if not, most likely up in the ICUs, these patients, we are trying to consider etomidate as the main agent for sedation, as well as some paralytics, rocuronium and succinylcholine. One thing to point out on the rocuronium dosing here is that we are considering going up to, instead of the 1 mg per kg, which everyone knows it as, to considering up to 1.5 mg per kg. This effect is dose dependent. So by going up on a higher dose, we can get up to almost 2 hours of true paralysis, where it may make it easier to consider adjusting the vent settings as appropriate.
Anthony, is ROC our first line because of that reason for the prolonged paralyzation? Because we want to get them so there's no cough reflex and get them all paralyzed as long as we can. Are we doing ROC first line?
I think generally ROC is being used first line. Maybe Josh can provide a little bit more on the rationale between ROC versus succinylcholine. But I do think that in fact it is mainly getting a longer duration for these patients. Another concern out there, a lot of nurses have come up to me, even if it's not about our patients, but it's about things that their family is reading, and they're getting concerned because now they just have general headaches, they're going stir crazy at home, whatever it may be. They're wondering if we should truly be avoiding ibuprofen, and where this concern came from is, shall we call it, propaganda on the right. In France, they did point out saying that some anti-inflammatory drugs, including ibuprofen, can be an aggravating factor for COVID-19. And where the concern is coming from is that the virus can potentially bind to these target cells through this ACE2 receptor. And by being on these medications, or on this enzyme, and by being on this medications, these are putting these patients at a predisposed risk. The hypothesis is that treating can stimulate the increase in the severity of this disease. But as of right now, there is no true literature telling us to stop using these agents in these patients. The World Health Organization created this advertisement that they do not recommend against the use of ibuprofen. And again, a lot of the American Heart Association guidelines and cardiology guidelines have started to make statements about how there's no data at this moment to support the discontinuation of ACE and ARBs in our patients.
I have a quick question. For the NSAIDs, does Rush have guidelines? Because I actually have a few patients who are admitted right now with COVID, and all the notes say avoid NSAIDs, avoid NSAIDs, avoid NSAIDs. So does Rush in itself have any guidelines to say, yes, we can use NSAIDs, or are we actually not using NSAIDs?
I do not believe that we have any guideline published or printed or a link somewhere for us to review regarding that specific concern. I think that we will continue to get these questions until either a study is published, either supporting or refuting it. I do think that the ID folks as well have not really come across anything that is convincing, worth publishing into maybe some of their treatment algorithms. So I would say right now that I have not seen any true recommendations we should be following that have been created by Rush. There are some order sets for COVID-19, specifically for these patients that are heading towards an ICU. I say heading towards an ICU because we have been fielding a couple questions regarding if we should be starting Plaquenil or hydroxychloroquine down in the emergency department. And again, I ran this by the ID pharmacists, who agree very similarly that if these patients in fact are presenting sort of at their moderate to severe stage with symptoms, and we are sending them to an ICU, it would be appropriate to start at least that loading dose, 400 milligrams BID for 1 day, and then ID would get on board and continue to either support the use of days 2 through 5 at the 200 milligrams BID, or they would determine the patient most likely won't benefit from Plaquenil. But overall, they also are not super sure if this is a convincing therapy at this time. But in their order sets, they do have the loading dose for Plaquenil built in, as well as only the use of acetaminophen instead of ibuprofen. But again, I think this is just an easier option for patients, and it kind of avoids the concern if we should be using ibuprofen or not for right now. And the most, I guess, or the strongest guideline that we probably have mentioning any sorts of COVID recommendations would be our Surviving Sepsis guideline that actually had made an update to add in some considerations for COVID. They touch upon PPE, which I'm sure we're all very familiar with based on the rush policies at this point. Again, for fever, they're recommending first line acetaminophen, mainly to avoid the concern of the unknown with NSAIDs. They also mention for hemodynamics to be considering fluids. Again, they're still favoring crystalloids over colloids for these patients, but not as high as what you would be considering for a true septic or septic shock patient, where you're considering at least 30 milliliters per kilogram in those patients. As well as here, they mention a MAP goal, which is 60 to 65, which is technically a little more lenient than what we know our septic or septic shock guidelines to be, a MAP goal above 65. But again, first line therapies of norepi, second line vasopressin or epi all remain basically the same. They mentioned for steroids to only consider low dose corticosteroid therapy for patients with refractory shock. And they also make some comments on neuromuscular blockade, whereas a lot of times we think ARDS, we begin to put these patients on continuous infusions at the study dose of, they believe it was 37.5 milligrams per hour. And based on some of that literature, that was essentially just the dose that was decided upon in trial in the study. They're determining these patients may not necessarily require as high of a dose, and we can also consider PRN boluses. And maybe someone who's up in ICU or more recently can correct me, but they're also doing this based on MD evaluation of the patient, determining when we should in fact be giving the next PRN boluses of these neuromuscular blockades, such as boluses of rocuronium. The Surviving Sepsis guidelines again mention considerations for antibiotics, and at this point in yellow, they mentioned there's really no controlled clinical trials evaluating the use of empiric antimicrobials in COVID patients or other coronaviruses. So at this point, I think it comes down to if providers are able to look at a chest x-ray or determine if patients are more likely to be bacterial versus having viral pneumonia. That may be in consideration. I know there is some discussion between what are COVID lungs, being more fluffy, more throughout, extending especially up in like the upper airways. But again, that is all going to come, I think, with more and more studies that we begin to see in these positive patients to be able to truly confirm what a COVID lung is. And just a resource I wanted to include here is this, this link, COVID19druginteractions.org. And what this is this brings you to, I think it's like a 9 or a 12-page document at this point that continuously gets updated. And they are looking at different medications that are interacting with our therapies that have been studied and or maybe no longer being studied. But what I wanted to include on this slide was some screenshots of the different paralytics as well as some of the sedatives that we're using. And we can see here that Kaletra, in fact, was interacting with a variety of these, and including this midazolam that I pointed out earlier, which would then increase the sedation in these patients and potentially prolong that as well. So in summary, when and who do we consider these therapies for? We can't really tell if it's going to be a survivor or non-survivor, again, until it's later on in the progression. Hydroxychloroquine is starting around when these patients begin to present and or get admitted to an ICU, which may be 4 or 5 days after they've already experienced symptoms, which is why I hovered it around day 6. Tocilizumab, again, for that cytokine release syndrome with the IL-6. I put that closer towards an ICU admission, sepsis, and ARDS picture in this graph, so around maybe day 12 or 10 through 12. Then remdesivir, I included a little later. Remdesivir, again, may be started sooner rather than what I have here on the slide. But again, this one is going to require a inclusion and exclusion considerations for the trials. One thing I want to point out here is that we are a clinical site for this trial. At this point, we do have very limited supply, so we may start to run into the issue of having multiple patients who meet the inclusion criteria. However, we have to begin to decide who is going to receive these very few doses. So at this time, I will take any questions. And just so everyone's aware, I believe all the other ED pharmacists are on this as well, if you guys have any particular questions for them.
Anthony, that's awesome talk. Couple quick questions. One is, how worried should we be about running out of nationally meds for sedation and paralytics on vents? Because I feel like, I don't know how great our stockpile is, but we're going to be using a ton of them.
So I will say that a couple of us are part of some email chains, some national email chains based on the organizations we are involved in. And every so many days, someone will reach out asking what other hospitals are using as alternatives. I do know some hospitals are pretty low on, I believe it is maybe fentanyl, as well as some other propofols. But again, I am just mainly speaking from what I'm seeing, as well as some of the people that I know are working over in emergency departments and ICUs in the New York area.
Yeah, our stocks here are pretty good still. I think fentanyl is starting to run short, and I guess we're gonna have some trouble getting propofol.
We can't hear you.
Maybe my mic doesn't work. Hello? Can you hear me?
Now we're good.
Yeah, so our fentanyl supply is pretty low. And we don't know when we'll be able to get that back in, and our propofol is kind of decreasing.
Wait, you went away again.
Can you hear me?
Yeah, just don't lean the other way.
Yeah. Whichever way you're leaning now, stick with it.
Okay, so our fentanyl supply is pretty low. And so you might see changes.
Nope.
Hello?
Yeah, now we can.
It's like whenever I say hello, it's just stop.
Maybe just type it in.
Type in the chat part.
Okay, I'll do that.